Yes,
I'm
as
getting
I
not large number of
Peter
data.
or Jack, as
VNS
we are able
has
to
freedom, complete seizure freedom. Another 32% have seizure control. VNS primarily more useful for children than adults, though in adults also it is being done. So I am not aware of comparative data, head-to-head trial of VNS versus DBS.
Right. Thank you so very much. And once again, thank you very much for sparing your time. And it's always nice to you.
It's my privilege to be there in this group. Really, I have taken snapshot, and next, whenever I'm meeting, I like to show all my friends who are there in this group.
Yes, it would be lovely to have you in person.
Thank you so much, Fauzia. Thank you so much. Thank you, Dr. Fauzia.
Thank you, Dr. Mahendrata, and thanks a lot.
I appreciate, yeah.
So with this, we conclude this session. And if you have no questions, I think it was very informative talk and very clear. People do usually, I think it was a very elaborate. So I don't think there are many questions from the audience. Do we have questions from online listeners, online participants? No? So,
I have a question.
Please.
Can I join for lunch with you all?
Please, you are most welcome. It would be great pleasure to have you with us.
Quetta was supposed to be my first visit, but somehow my bad luck, I could not make it. Yeah.
Right.
So next time, inshallah, we will be.
Yeah, inshallah, yeah. Sure.
Great.
Let's break
thank
for
you,
lunch.
Thank you so much.
Thank you
Shukriya. Thank you. Bye-bye.
Now it's the time for the lunch break. Okay, it's 30 minutes. Okay, so please be in time for the next session after the lunch.
Davut'a aşağı tane banner kaysa. Banner kaysa.
अस्सलाम वालेकुम मेरा नाम प्रोफेसर मोहम्मद सलीम बड़े जबल इंस्टीट्यूट ऑफ मेडिकल हेल्थ साइंसेज क्वेटा और अस्सलाम वालेकुम मेरा नाम प्रोफेसर मोहम्मद सलीम अस्सलाम वालेकुम मेरा नाम अस्सलाम वालेकुम, मेरा नाम प्रोफेसर मोहम्मद सलीम बड़े बोला इंस्टीट्यूट ऑफ मेडिकल हेल्थ साइंसेज क्वेटा और करंटली मैं प्रेसिडेंट पाकिस्तान सोसाइटी ऑफ न्यूरोलॉजी हूँ। आज ये जो हम कॉन्फ्रेंस ये 27th न्यूरोलॉजी एनुअल कॉन्फ्रेंस है। लास्ट ईयर कोविड की वजह से हमें ये पोस्टपोन करना पड़ा और अब हम अल्लाह करे कि ये खैरियत से काम पजीर हो। तो इसमें चूँकि हमने हाइब्रिड रखा हुआ है तो इसमें हमने दोनों ऑप्शन रखे हैं और लोग यहाँ पहुँचे भी हैं मुख्तलिफ सिटीज़ से, पाकिस्तान के मुख्तलिफ शहरों से। हमारे जो न्यूरोलॉजिस्ट हैं, कंसल्टेंट हैं, रेजिडेंट्स वो आए हुए हैं और साइंटिफिक सेशंस स्टार्ट हो गए हैं और ऑनलाइन भी लोग अटेंड कर रहे हैं। होपफुली कि ये बड़ा अच्छा नाम प्रोफेसर मोहम्मद सलीम बड़े बोला इंस्टीट्यूट ऑफ मेडिकल हेल्थ साइंसेज। अस्सलाम वालेकुम, मेरा नाम प्रोफेसर मोहम्मद सलीम बड़े बोला इंस्टीट्यूट ऑफ मेडिकल हेल्थ साइंसेज क्वेटा और करंटली मैं प्रेसिडेंट पाकिस्तान सोसाइटी ऑफ न्यूरोलॉजी हूँ। आज ये जो हम कॉन्फ्रेंस ये 27th न्यूरोलॉजी एनुअल कॉन्फ्रेंस है। लास्ट ईयर कोविड की वजह से हमें ये पोस्टपोन करना पड़ा और अब हम अल्लाह करे कि ये खैरियत से काम पजीर हो। तो इसमें चूँकि हमने हाइब्रिड रखा हुआ है तो इसमें हमने दोनों ऑप्शन रखे हैं और लोग यहाँ पहुँचे भी हैं मुख्तलिफ सिटीज़ से, पाकिस्तान के मुख्तलिफ शहरों से। हमारे जो न्यूरोलॉजिस्ट हैं, कंसल्टेंट हैं, रेजिडेंट्स वो आए हुए हैं और साइंटिफिक सेशंस स्टार्ट हो गए हैं और ऑनलाइन भी लोग अटेंड कर रहे हैं। होपफुली कि ये बड़ा सक्सेसफुल होगा और साथ ही मैं आदमजी फार्मा को मुबारकबाद देता हूँ कि उन्होंने भी इसमें अच्छे अंदाज से कंट्रीब्यूशन की है इनकी, चूँकि बड़ी अच्छी कंपनी और बड़ी एक एडवांटेज ये है कि बाकी मैं जो खुद देखता हूँ इनकी प्रिस्क्राइब में काफ़ी करता हूँ मेडिकेशंस, तो बड़ी सस्ती हैं और बड़ी अच्छे रिजल्ट हैं इनकी मेडिकेशंस की। एक दफ़ा बहुत शुक्रिया अदा करता हूँ मैं आप सबका। थैंक यू। अल्लाह हाफ़िज़।
The reason I love using StreamYard, well, that's easy. I can make me, Chris Brogan, I can make a show like the Backpack
can see that, okay?
Yes, yeah, it's coming.
Coming.
Shazia.
Yeah, that's it. You can see it?
Yes, absolutely.
Great. Okay, fine.
Great.
Shall I leave it on this setting then, or?
Yep, please.
Fine. Great. Okay.
Thanks.
Do that.
Bhai, how are you?
शुक्र अल्हम्दुलिल्लाह जी, आप खैरियत से हैं जी?
Shazia.
Sorry. Assalamu alaikum. I'm not sure who I'm talking to. I
Oh,
can't see
you
it. I'm on my share screen, so all I can see is my slide.
That's good, but you can see us on the right.
I can see just, yes, I can see ARs on there, right? I can't see anyone else at the moment. But I need to maximize that.
How's the weather in London?
It's you. That's fine. It's fine. It's dull, but yeah, probably not as cold as in Hull.
Same in Hull, cloudy, dull. It's a bit cold, but obviously only outside.
Cold bank holiday weekend, typical, huh?
Yeah, I think it was forecasted to be snowing on Sunday or Monday.
I think you guys will get some snow.
That's what it said. How's Peshawar? Oh, Quetta, sorry.
Sir, I'm in Peshawar. Basically, a couple of my colleagues contracted corona, so I was on my own on the neurology floor. So I couldn't leave the ward.
So you are in Peshawar. The meeting is taking place in Quetta.
Yes, sir.
Is it all working well, technology-wise?
Yes. So far, so good. Yeah.
Okay. So you're coordinating, you're controlling the screen and things, are you, or is it somebody else?
Basically, there's a local team who is controlling everything. Yeah.
Fine. Okay. Great. Okay. Good. Yeah. Fine. We just got a kitten yesterday, Fayaz. A new kitten.
Oh, wonderful.
I know. So it's taking up some time. So we'll take it to the vet later. But yes, that's our excitement for the weekend.
All right. Yeah. Well, I mean, we still celebrating our new home. We moved in 2 weeks before the lockdown last year.
Oh, did you? Really?
Yeah.
Oh, we moved in January. So yeah.
So it's been a year now.
Wow.
A year for the lockdown and a year for the new move. So we're still enjoying the new home.
That's nice. Yeah, there's lots to do. Yeah, we moved in January, so it's been 2 months only for us. But again, lots of things to get organized and things. Yeah, it's nice.
With everything going virtual now, I think it's no travel.
Much easier, isn't it?
Much easier, yeah. In one way.
Yeah. In another way, you don't get to see people so much. So yeah.
Yeah, but there's very little networking.
Yes, true. Yeah. Wow. Let's see what happens. I think this year's all going to be virtual again, isn't it?
Yeah, I think September IHS is virtual.
It is, yeah.
We postponed the Hull meeting to 2022, but I think it's going to go virtual. I think we would do it Hull meeting next year anyway. But
I think this is winter as well. It will probably have to be, won't it? Yeah, there'll be another outbreak winter.
But I want to do it virtual because obviously Allegan has the money put in.
Yeah.
We might as well get the money.
Yes. Yeah. Good idea.
Yeah, absolutely. Because I think our incomings have gone down since this. Oh, by the way, I was going to ask you, Shazia. Have you been in touch with Anne McGregor?
No, about what?
Well, about this June thing. You're doing it, isn't it? I asked Manuela, you and Anne, and I've sent quite a few emails. She hasn't replied. That's very unusual for her.
No, I haven't really. I'm not that much in contact. I only ever see her at meetings, really. So
yeah, because she's always been extremely good in replying to email, and I have sent her about 2 or 3. So I was a bit worried about is she okay? I haven't got her telephone number.
I don't either, but maybe she's got a different email. Have you tried? Maybe she's moved or retired or something from her practice and.
Yeah.
Have you tried on NHS Net?
I would try next week, and try and
Try
bring
NHS Net
her
because
to the
yes,
hospital.
even if she moves, she'll still have NHS Net, won't she?
Yeah, because it's very unusual for her not to respond for the June meeting. Have you had a chance to attend any of our webinars?
I haven't yet. No, sorry.
Oh, they're going well. They're going well.
Good. Are they good?
We get about 350 people registered,
Right.
but I think the attendance is around 200.
That's very good.
I think a lot of people are not attending in live because it's all available on iCloud and it's all available on the Bash YouTube channel.
Yes. So it's easy to watch when you have the time. Yeah.
Yeah. And it goes live on the Facebook, so they can always go to Bash page and watch it again.
Okay. Good.
It's doing well. So we got some money because of the webinars. But I think if we don't do any Hull meetings or any other meetings, I think we would get to this situation where we would struggle to have any funds in the.
No, I think that's right. I think it'd be good to do that virtually, though. I think. Yeah.
Yeah, virtually would be. That would probably be the next one. So I think we would have 2022 and still keep 23 as our face to face and see how it goes. But I don't think it's going to go away in the next 1 year.
It's not. No, it'll definitely flare up in January. So yeah.
Okay, good. Yeah, look forward to listening to your talk.
Okay, thanks. You too.
Okay, thanks. Okay, I'm just going to have my breakfast while I'm watching, yeah?
Please. Sir, bas wahan wo lunch ho rahi hai. I think they will be back in a minute or two. Sir, your previous house was in a very nice location, so why did you move then?
Well, this is another very nice location.
So I had to come to see it then.
Yeah, I'll see if my wife comes. She can say hello. She hasn't seen you for nearly 10 years since you left Hull.
Exactly. That's
Shazia Ayaz was my registrar.
Oh.
About 11 years ago.
Oh, really? Okay.
Then I think he moved to Preston. He completed his training, got his CCST in Preston. But then he decided not to have a consultant job in UK, and he went back to Peshawar. I think he loves Pakistan.
That's good. So you're working in Peshawar now, are you?
Yes, yeah.
Oh, and my father's family from the northwest frontier. So.
Yeah, whereabouts?
Well, they originally they were from Jamrud, but obviously they live in the city now. And yes, yeah, they live in Peshawar. So yeah.
Well, we all know where Afridis come from.
Yes. The surname gives it away, doesn't it? Yeah.
Jamrud is about 10-15 minutes drive from us. So
yes.
I think
when
the borders are open, we should invite you. You should.
Oh, yeah, inshallah, yes. Unfortunately, I haven't been back for a while, but yeah. Well,
we'll get you around. It's such a nice location. It's a beautiful area.
When things settle down, it will be great to come back. And yeah.
I miss because I used to go face to face. I mean, 2 years ago, the meeting was in Karachi. I went there in person. I think I quite like to go in person rather than virtual.
Yeah. Well, it's nice when you're traveling, when you're able to travel around. Yeah.
Yeah, that's the thing I miss. Adnan, how are you?
Assalamu alaikum ji. How are you, sir?
I'm all right. How are you?
Thank you very much, sir.
We can only see your eyes.
Oh, so sorry. I'm sorry.
Yeah, no, that's good. That's good.
Alaikum, sir. Sangal ji, khair de.
Khair de, mehrbani ji.
TikTok, Jory, sir.
Adamjee, do you understand Pashto?
I understand it, but I don't speak, unfortunately. Yeah. My mum doesn't speak Pashto, so yeah.
You speak a little bit Urdu, isn't it?
Yeah.
Little bit or quite a bit?
As an English person would speak.
You probably speak similar. You speak similar Urdu like my daughter does.
Yeah. I can understand it all, obviously, but I don't speak it very much anymore. So yeah, completely understand it though. Yeah.
No, you should come and visit Jamrud because it's such a beautiful location. It's not very far from Peshawar, 10-15 minutes.
Yes, no, I have been before because I still have relatives there, but I haven't been for a very long time back to Pakistan. So yeah, it'll be nice to come, inshallah, when things settle down.
When was the last time you went there?
2001, long time ago. Yeah, yeah.
20 years.
I know. But yeah.
The houses are still sort of mud built, and
Yes.
the people around, they're very friendly.
I know, they're lovely, very hospitable. Yeah, very hospitable.
Exactly. I've
Yeah.
been there like 10, there was a couple of weeks ago, I had to go and see my friend. So, and Babi Khyber, you can see Babi Khyber and just
Yes.
and
I've been there. We used to go more regularly when I was young. We used to go every 3 or 4 years. So yeah, we used to go a lot, basically to Peshawar and Karachi. My mother's side were in Karachi, my father's side in Peshawar. So
right.
it was
And same like my daughter. We used to take our daughter every year.
Yeah.
In this pandemic, and I think she's gonna tell the same story in 10 years' time.
No, let's hope things settle down. So yeah. Good.
Okay, wonderful. See you around then.
See you later. You know when they're about to start? Is it running 5-10 minutes later?
It should have been started 10 minutes earlier. I will give them a ring.
Okay. All right. Hopefully they're not waiting for me.
We found this food bag in the store. Okay, where should I keep it?
Assalamu alaikum, Dr. Afridi.
Walaikum salam.
This is Professor Dr. Adnan Khan.
Oh, nice to meet you.
Same here.
So are you currently in Quetta or?
No, I'm not in Quetta actually. I'm in Peshawar.
Ah, okay. All right. Okay. So
yeah.
It's virtual for you as well then.
Thank you very much. And it's actually, I'm head of the Neurology Society.
Oh, I see.
Yeah.
Okay, so you help organize the meeting then?
No, not me, man. Basically, it was done by the Salim Balaj and all those. They did it. Yeah.
Okay. Great.
Anyway, it was a nice meeting you actually. I think we'll learn a lot from you.
Well, I don't know
Inshallah,
about that, but let's hope something will come out.
No, inshallah, I'm sure because we are quite backward in these headaches and all those things because most of them are pseudos and some are because of this terrible situation over here. There are a lot of problems. especially in female.
Yes, yes. I guess
They-
it's a priority.
they don't actually have headache, but they have some sort of odd behaviors, just banging their heads on the wall and all those things, and
Yeah.
abnormal behavior and all those. And some of them they're getting pseudo-fits and all those things.
Oh, I see. Yeah.
It's,
That to you.
that's quite terrible, actually.
Mm.
Do you do practice there or there?
Sorry?
Do you do any practice over there?
Yes, yes. I'm a consultant in the Guy's and St Thomas's in London.
And do you do your private practice also?
I've recently started that a bit as well. Yeah, I was mainly NHS for the last sort of 8-9 years, but then this year I started a little bit of private practice. Yeah.
Is it dangerous or not?
Well, I try and restrict it.
Okay.
That's the key, I think. It can
Yeah.
be quite challenging. I try to only see headache. I mean, I'm a general neurologist, but my specialty is in headache.
That's good.
So I set up the headache service at Guy's at St Thomas's, and
All right.
so I work.
All right.
Yeah, but yeah, I do some general as well, but mostly in private. I just see headache really because it's just easy.
All right.
Yeah.
I think we'll have some questions because my daughter keeps on having headache, and I don't know. She's afraid of taking topiramate and all those things
All right.
because she thinks that I'll become drowsy and won't be able to study.
Oh,
So-
well, there are different things to try. There's many different things to try, aren't there? So maybe she can try a small dose and then see if slowly increasing it
Okay.
and slowly bringing it up to see if that helps. Otherwise, there are many different things to use now in migraine. There's lots of different options available.
Nothing new in cluster headaches, I think so.
Well, the CGRP monoclonal antibodies are coming out for that as well. Yeah. So
Okay.
there's things like vagal nerve stimulation. So there are things around, but at the moment, most of the focus is what's coming out in migraine because it's more a larger population of people having migraine.
Okay.
Yeah,
Okay. That's good.
yeah. It's all good. Lots of new drugs coming out. So
All right.
yeah.
Sorry to keep you waiting. I've contacted Ahmed Wali. They're
That's
saying
okay.
they will be back soon. They're
Okay.
having lunch, so it won't be long.
It's Pakistani timing, isn't it? Really.
Yeah.
I'm familiar with that. Yes.
Yeah, that's correct.
Different to the European meetings.
No, that is very 100% true. You have to go 1 hour late for a wedding.
Yeah.
Otherwise, your importance, there is no importance of yours if you go on time.
Yes, exactly.
So you have to show them that, okay, yes, I am
I'm
important.
important. Yeah.
Yeah. This is that's all over
Traditions.
Pakistan anyway.
Yeah, it's true. Yeah. People still having their lunch, I'm sure. How many people are logged into the meeting? Do you know?
Not exactly. I didn't count them actually, but there are a lot of doctors there,
Yeah.
and a lot of general practitioners also.
Okay.
Yeah.
And it's a hybrid one, so the few present there physically.
Oh, okay.
Yeah.
And I'm not sure, is there much contraception use in Pakistan? Because part of my talk is about contraception, and I don't know, I'm not familiar with how much of that is used in Pakistan.
I think it will be useful to be. The problem over here is that there is no sort of like coordination among the gynecologists and neurologists or obstetricians. So
Yeah.
it will be a very good talk.
Okay.
अस्सलाम वालेकुम हेलो
अस्सलाम वालेकुम जी
वालेकुम अस्सलाम जी we can start now Dr. Nasrullah साहब मैं आपको कोच बना दिए so you
जी, जी।
can take, the, lead.
जी स्लाइड अभी शेयर हो गई है पहले स्पीकर
डॉक्टर शाजिया अफरीदी ने अपनी स्क्रीन शेयर की अभी तक कर ली.
I've shared my screen. Yes, it should be shared. You should be able to see it.
Yeah, it is visible. Yes.
Great.
Okay. Dr. Ahmed Wali, can we start?
Yes, sir. You can start.
Okay. Bismillahirrahmanirrahim. I am Dr. Mohammad Nasrullah, moderator of today's session. I am General Secretary, Pakistan Headache Society and member Executive Council of Pakistan Society of Neurology. Today's session on headache, I will request Dr. Aziz Sonawala, previously announced as chair of the session, is busy in his parent institute. He has some unavoidable meeting. So meeting will be chaired by Professor Dr. Adnan Khan, President, Pakistan Headache Society. I will request Professor Adnan Khan to take the responsibilities of the chair of the session. And I will request Dr. Mia Ayazul Haq, Vice President, Pakistan Headache Society, to act as co-chair. And now we start with the proceeding of the session.
Thank you very much. I actually welcome Dr. Shazia Afridi and hope you will have a very nice lecture and learn a lot from her.
Thank you.
Our first speaker is Dr. Shazia Afridi. I will like to give a brief introduction of Dr. Shazia Afridi. Dr. Shazia Afridi trained at Guy's and St. Thomas Medical School and attained an intercalated neuroscience BSc and MBBS honors. Following her medical training in London, she completed her PhD at the Institute of Neurology, Queen Square, looking at functional imaging in migraine. She has went on to complete her higher training in London. Shazia was appointed as consultant neurologist at Guy's and St. Thomas Hospital in 2013 and established the headache services in the neurology department. She has been on the council for the British Association for the Study of Headache and is a trustee of the Migraine Trust. She is also visiting senior lecturer at King's College and has published over 30 peer-reviewed papers. She is on the scientific committee for the Migraine Trust International Symposium. I will like to take this opportunity to tell about this scientific session. This scientific session has been dedicated to Professor Akhtar Ahmed Khan Memorial Session. Professor Akhtar Ahmed Khan is one of the pioneers of neurology in Pakistan. Born in 1935 in Hyderabad, Deccan, he graduated with honors from Dow Medical College, Karachi in 1957, ranking first and received Mystery Gold Medal. Became the member of Royal College of Physicians of Edinburgh in 1962 and was awarded Fellowship of Royal College in 1978. He became in charge of mental retardation project at Jinnah Postgraduate Medical Center from 1964 to 69 and received a WHO Fellowship in Neurology in 1979. He was appointed assistant professor and founded the Department of Neurology at Dow Medical College and Civil Hospital, Karachi in 1970 and became professor of neurology in 1985. He was awarded honorary fellowship by College of Physicians and Surgeons of Pakistan. He was the first CPSP examiner for neurology candidates. His research interests include subacute sclerosing pan encephalitis, SSPE, and mosquito-borne neurological pathogenesis. He worked extensively with Japanese researchers on the arthropod-borne encephalitis and SSPE in Karachi. He also worked on neurometabolic disorders causing the mental retardation. He produced 6 FCPS and 2 MD postgraduate fellowships. He was awarded Lifetime Achievement Award by Division of Neurology, Shifa International Hospital in 2007, and he was awarded Professional Excellency Award by Dow Medical University of Health Sciences in 2013. Now we start with our talks. First talk by Dr. Shazia Afridi on migraine in women. Dr. Shazia Afridi, please.
Thank you very much. Can you hear me, first of all?
Yes, we can hear you, madam.
Great. I'd like to thank the Pakistan Society of Neurology for inviting me today to give this talk. It's a pleasure to come and do so. As my family is originally from Pakistan, so it's nice to get back in and share some information and knowledge. So I've been asked to talk to you about headache in women, and really I've changed the topic to migraine in women because basically if you're a neurologist and you have a woman who's presenting with troublesome headache, the likelihood is going to be migraine. And the only other sort of more relevant headache is the idiopathic intracranial hypertension, and Professor Ahmed is going to talk to you about that after this. So these are my disclosures. And these are the topics that I plan to cover over the next half hour or so. So I'm going to talk a bit about menstrual migraine, contraception, pregnancy, and the menopause. So just to refresh your memory, this is the International Headache Society's criteria for diagnosing migraine. So you have to have at least 5 attacks fulfilling these criteria. So the headache lasts anything from 4 hours to 72 hours. It has to have at least 2 of the following features. So unilateral, but it can be bilateral. Often has a pulsating or throbbing quality, quite moderate in pain intensity, but can be very severe. And aggravation by exercise. So when patients have migraine, they don't want to be running around or walking around. They want to keep still. They often want to lie down. And during the headache, you need to have nausea and or vomiting, or photophobia and phonophobia. So you don't need to have all of those features. They may just have phonophobia. They may just have photophobia. But those are the features that make up a migraine episode. And migraine is a very common headache, actually. So the prevalence is about 15% worldwide. So, and that tends to be the same whether you're in the East or in the West or in different countries. It tends to be quite a consistent prevalence, 15%. And when you look at the male to female preponderance, well, it's 3 times more common in women. But actually that ratio only applies after puberty. So before puberty, sorry. Sorry, can you hear me? Is that right? Should I carry on? So after puberty, before puberty, the ratio is 1 to 1, and after it's 3 to 1. 3 times as many women are affected by migraine. And in fact, if you look at women of childbearing age, about 1 in 4 women of childbearing age has migraine. So it's very common. There's often a misconception amongst the public and also sometimes amongst doctors that you have to have migraine aura in order to have migraine, and that's not true. So most people, 2/3 of migraineurs don't ever have any aura at all. They just have migraine without aura, so without any visual disturbance or numbness or tingling. And then looking at the age of onset, so this graph in red is the female and the blue is the male. So you can see it's very common amongst people in their teens, 20s, 30s, 40s, and then as we get older, it's less common. So this is a nice graph depicting the way that hormones influence migraine. And the reason that migraine is more common in women after puberty is to do with hormones, of course. And the main hormone that's important is estrogen. So that's depicted in dark blue here, this dark blue image. And this is, if you look here, this gray peaks signify the peak of migraine. So this is a peak that you'll get in the menstrual cycle around the menstrual period. This is a peak when a woman is pregnant and has just given birth, so after the delivery. And then this is a perimenopausal peak. So I'm going to talk a bit about each of those phases separately. So estrogen can trigger aura in women who don't have migraine with aura. So for example, in a high estrogen state like pregnancy, or if a woman's been started on the combined oral contraceptive pill, which contains estrogen, or hormone replacement therapy, for the first time, she may experience aura. And that is to do with the estrogen component. We also know from studies that women who have migraine with aura have a high estrogen component in their menstrual cycle, and that estrogen withdrawal triggers an episode of migraine, and that's relevant when you're thinking of menstrual migraine. So just to remind you, this is what happens to your hormones during a woman's menstrual cycle. So you have the estrogen going up, drops a little bit during ovulation, goes up again, and then drops just before menstruation. This is the menstrual peak here. And so about 50% of women who have migraine will notice that there is an exacerbation around the time of the menstrual period. And that can start anything from 2 days before onset to the day of onset of menstruation. And that's because of this drop. So you have this drop in estrogen, which then triggers the migraine episode. And we know that from studies done in the 1970s. There was a chap called Somerville who gave women estrogen supplements around the time of their period. He gave them progesterone supplements because the question was, is it progesterone, which is also dropping, or is it the estrogen? And he found that if you gave estrogen supplementation, that would abort the menstrual migraine attack, whereas if you gave the progesterone, it had no effect. So it became clear then that estrogen was the culprit there. So as I said, it's related to the drop in estrogen. And there's also research studies showing that there's a faster luteal phase decline. So there's a faster drop in patients who have migraine and then the patients who don't have migraine. Prostaglandins may also be involved in this as well. What we know is that even if a woman has migraine, whether it's migraine with aura or without aura, the attack that they will get during their menses will be a more severe attack, and it tends to be migraine without aura. And it's often less responsive to medication than at other times of the month. So how do we manage this? Well, this is a table taken from a review I did in Practical Neurology. So it depends on whether the menstrual cycle is regular or not. So if a woman can predict her menstrual cycle, so say if it's every 4 weeks and she knows roughly when she's going to start, then she can plan to take a drug starting 2 days before onset and taking it every day for a period of about 5 days. So you can do that with a non-steroidal anti-inflammatory drug. So you can use naproxen, 500 milligram BD, or mefenamic acid. And similarly, you can use a triptan. So triptans are specifically for migraine. And you would use one of the longer acting triptans. So for example, Provocative, I'm not sure if that's available to you in Pakistan, but it's one of the longer acting triptans. And you can take that twice a day, starting 2 days before the beginning of the period is expected. And then you take it every day for like a consecutive sort of 5-day period up to about a week. And that's to try and cover for that period where the estrogen drop is triggering a migraine. Now, if you can't predict, so some women have an irregular menstrual cycle, then you can think about hormonal mechanisms and hormonal methods of treating it. And one way is the combined oral contraceptive pill. So the combined pill meaning has estrogen and progesterone. And so normally when the pill is taken, it's usually taken for 3 weeks. And then there's a 1 week period where the woman stops the pill and has her menstrual period. So if you take it back to back for 3 months, then you only have a period once every 3 months. Therefore, the migraine once every 3 months. So that's another way of doing it. Or you can also supplement with something called a vaginal ring, which is another estrogen supplement. Other ways are making the pill-free period shorter. So instead of having 7 days off the pill, you can have 4 days off the pill. That means your migraine period is shorter. And then there are other methods of contraception that don't involve estrogen. So there's the progesterone depot, and there's something called desogestrel, which is a progesterone-only pill. And there's some evidence that it's some improvement in migraine in women who take those methods of contraception. So the next topic I'm going to talk about is contraception and the effect of starting one of the contraceptive methods on migraine. And then the second issue is the safety issue. So the safety issue really relates to the risk of stroke because over the last 2 decades, it's been demonstrated that women with migraine with aura have a slightly increased risk of stroke, so a 2-fold increased risk of stroke compared to women without migraine with aura. And there were some studies looking at other factors that are relevant, and they found that women who are taking the estrogen-containing combined contraceptive pill had a further increased risk of stroke. So I'll talk a little bit about that in a minute. Of note, the progesterone-only component pills, so the progesterone injection, progesterone implant, progesterone pills, they don't have that increased risk of stroke. So they are safe in terms of taking them with migraine with aura. What happens when a woman starts a pill? Is your migraine going to get better or worse? Well, it's very difficult to predict. If someone has migraine with aura, the likelihood is it might get worse. But, you know, the studies have shown anything from 18 to 50%. So, you know, that doesn't tell us anything really. So I think it's very difficult to predict. There's some, as I mentioned earlier, there is some studies with desogestrel, which is a progesterone-only pill, and suggesting that there is some improvement in some women who take that. So you could try that, and if the woman is better on that, you could also think about longer-acting progesterone-type depot injections. So what is the guidance? Well, I put national for the UK, but international guidance is the World Health Organization. And then this is the European Headache Federation consensus about the use of contraception in women with migraine. And as I mentioned, the reason that this is an issue is because of risk of stroke. So currently the recommendation is that if a woman has migraine with aura, that she should not be prescribed an estrogen containing pill, and she can take a progesterone containing pill, but not the estrogen one. And the reason for that is these studies that were done, as I said, starting about 2 decades ago, in fact. And I put these in chronological order. So this is the oldest, and this is the most recent study looking at stroke and migraine. And as you can see, with migraine with aura, there is an increased risk of stroke, probably not so much with migraine without aura. But the thing to note here is that the data that was used to come up with these figures is mostly data from the last century, when the combined contraceptive pill had a very high estrogen component. So it used to be about 50 micrograms of estrogen, and that was normal. Now it's 20 micrograms. So the pill that women use now with estrogen is a different type of pill, and has a different risk. But unfortunately, the data that we're all using to try and determine this risk of stroke is old data, and there isn't any good new data. This is a study done in Denmark, I think, looking at women who, nothing to do with migraine, just women on the pill and their risk of stroke. And as you can see, so if your estrogen component is 50, you have a different risk of stroke than if your estrogen component being 20. And these are all the progestogen components as well. And again, this is just to highlight that this is a meta-analysis done looking at how the dose of estrogen affects your stroke risk. So as you can see here, the high doses, you have a very high risk of stroke comparatively. And then at low doses, much lower. So as your estrogen dose decreases, so does your risk of stroke. And then the progesterone only pill does not increase your risk of stroke. But actually, what does that mean to a woman? So if you tell them your risk of stroke is doubled, that sounds quite alarming. But actually, if you look at the actual risk of stroke, so this is the risk of stroke according to age. So if you're looking at a young woman in her 20s, a risk of stroke is 2.2 to 3 per 100,000. So that's a very small risk anyway. So thinking about doubling that, that goes from say 3 in 100,000 to 6 in 100,000. Okay, so you've got to put it all in context. Also, the studies looking at the increased risk with migraine with aura tended to be to show that if you have a lot of attacks, so if you have very frequent attacks, your risk is higher. If a woman has 1 or 2 attacks a year and she's young, actually her risk of stroke is very low. So it's unfortunate that we have to go by this guidance and say, well, that you can't have an estrogen containing pill, because in realistic terms, her risk of stroke is actually not that high. But until we get better data, unfortunately, we have to follow those guidelines. The other thing to mention is smoking, and probably not so much of an issue in Pakistan with women, but women who smoke and are on the pill and have migraine with aura, there's a cumulative increased risk of stroke. So the increased risk of stroke is about 7-fold if a woman is a smoker and is on the pill and has migraine with aura. So these are all risk factors that you have to look into. When would you discontinue the combined oral contraceptive pill? Well, I guess some people would discontinue it if a woman presents with aura, and that's because of this, what we just discussed. If someone starts to develop more persistent headache, then obviously you'd stop it anyway, because if someone's headache's getting worse, you want to try and stop the thing that started that problem. Or if anyone has an increased headache frequency or intensity, so that's when you would discontinue the combined oral contraceptive pill. So I'm going to mention topiramate here. So if we prescribe topiramate quite a lot in migraine and also in epilepsy. And it's important that the woman knows that she should be using contraception if she's on topiramate, because there's a teratogenic risk. We don't tend to use valproate very much anymore in migraine, but we do occasionally. And again, if you are using valproate, you need to ensure that the woman is on contraception, because that is highly teratogenic and also associated with neurodevelopmental problems. So that is the most severe sort of teratogenic issue. Topiramate also has some teratogenicity as well associated with cleft palate and things. But the issue with topiramate is it does interact with the combined oral contraceptive pill. So a woman may be on the pill thinking that she's safe to take that, but actually the topiramate makes it less effective. And therefore, it actually interacts with pretty much all of the contraceptives except for the depot injection of progesterone and except for the coil, the Mirena coil. So you have to be careful because she may get pregnant thinking she's covered, but actually it makes it increases the metabolism of the pill. So moving on to pregnancy. Well, the good news for pregnancy is that most women, up to 90% of women, will get better by the end of the third trimester. So the first trimester might be a little bit rocky, and there's various reasons for that. The hormones are changing, and there may be some morning sickness, and et cetera, et cetera. So it might be a little bit worse around the first trimester. But as the estrogen increases, and you can see here estrogen in blue going up throughout pregnancy, then actually the migraine improves most of the time. So that's good. Sometimes women present with an episode of aura for the first time, and as I mentioned before, that's due to the high estrogen level. But then the bad news is that, of course, once the estrogen level drops after the delivery of the child, then there's often a postpartum exacerbation. So that's multifactorial. It's mainly due to hormonal change, but also if you think about anyone who knows has had a young child, and the woman is tired, she's sleep deprived, she's maybe missing meals. So all of these are normal migraine triggers anyway. Stress, lack of sleep, missing meals, and the screaming baby. It's a good enough reason to have lots of migraine, but it's compounded by the fact that the estrogen level has dropped, and that's making more sensitive to it. What can you give women during pregnancy? Well, you can give quite a few things, because there's sort of thought is that you can only give them paracetamol and nothing else is safe. Well, actually, that's not true. So paracetamol is safe, yes, but it doesn't always work. So you can try that first. You can also give non-steroidal anti-inflammatories. So ibuprofen and naproxen you can give with the first and second trimesters, but not after 32 weeks, because that's when the patent ductus arteriosus closes. So up to 32 weeks, you can also give non-steroidal anti-inflammatories. Triptans, you can give sumatriptan, and I'll talk a little bit about that in a minute. And then I put metoclopramide down. So that's prokinetic and antiemetic as well. So when a woman has migraine, when anyone has migraine, in fact, you get stasis, gastric stasis. So giving metoclopramide helps you absorb your analgesic orally, but also obviously has an antiemetic effect. And then I put GONs here. So GON is a greater occipital nerve block. So that is something that's done in headache centers. It's usually a mixture of steroid and local anesthetic, but the studies showing that it's safe in pregnancy are done just with a local anesthetic component. So we offer that in our center to women who are pregnant as a kind of sudden, quick fix, quick temporary fix. So this is the triptan data. So we've had triptans around for about 20 years now. And this is all the data coming from mainly the Scandinavians. This is why I put these pictures up. This is Alfred Nobel, the Nobel Peace Prize fame, representing Sweden. And this is a picture called The Scream by Edvard Munch, who's a Norwegian artist. So you can see here that Norway produced a large amount of data, and Sweden, more than 2,000 women. So we have over 4,000 women now who have been exposed to triptans during pregnancy. So we've got quite a good database on that. And the meta-analysis shows quite reassuringly that there is no increased association of congenital malformations with triptans and no increase in spontaneous abortions. So I think it's pretty safe to take during pregnancy now, and that's quite reassuring. What about preventatives? Well, I already mentioned you wouldn't use provalproate, you wouldn't use topiramate. What can you use? Well, you can use beta blockers, you can use propranolol. Nothing is risk-free. So ideally, a woman wouldn't use anything. But then equally, if she's suffering with severe migraine and vomiting and ill, that's not healthy for the fetus either, okay? So you've got to get a balance right. And so if you are going to start a preventative, you can start propranolol or amitriptyline. And those are the two that I would use if I was having to use a preventative. If you want to use something a bit more natural, you can try acupuncture, some evidence there. And also magnesium. So there's some evidence for magnesium as a migraine preventative at 400 to 600 milligrams a day. And women are often given magnesium by the obstetrician for other reasons. So that's also something to try, although there's a recent paper showing that intravenous magnesium at high doses can be associated with fetal bone problems. But I think the doses that you would use in migraine would not be that high. So it's probably all right. And then I put Botox here because Fayaz Ahmed, who's going to give you a talk after this, has done published a paper. I think 45 women who happened to have got pregnant while they were taking Botox, and I think 32 of those continued using Botox during their pregnancy, and there was one miscarriage, but the others were fairly healthy. So, again, small numbers, but potentially something that we could use. Although, I think it would be good to get bigger numbers on that. Now, I'm not sure whether you have access to these are new drugs, CGRP monoclonal antibodies. So I'm not sure what access you have in Pakistan to that. These are just coming in over the last year or two. We've been starting using these. Our National Institute of Clinical Excellence has approved the first drug in September of last year, actually. So these are drugs, erenumab, pramanazumab, galcanezumab. These are CGRP monoclonal antibodies, which are the brand new thing in migraine. Very exciting thing, actually, because patients who know not responded to other drugs, they may have failed 3 or 4 preventatives, they may have failed Botox. They are starting to respond to this new treatment. And this is given as an injection, which the patient injects himself every 4 weeks. So because this is relatively new, it was started probably a couple of years back in America. There is some data on pregnancy in that. There's about 92 patients who've used these antibodies during pregnancy. And from that paper, it shows about 20% have had spontaneous abortions, and there have been 2 birth defects. So at the moment, we recommend that women don't get pregnant on this because we don't have safety data on it. So just to summarize what you can use in pregnancy. So acutely, you can use paracetamol and non-steroidals. You can use sumatriptan, metoclopramide. As a preventative, you can use propranolol, amitriptyline, greater occipital nerve blocks, acupuncture and magnesium, Botox possibly, and riboflavin possibly as well. It's one of these sort of vitamin B2 type drugs, which the dose is an issue because in migraine you use very high doses, and so we don't have safety data on that high dose in pregnancy. And then what about breastfeeding? So what can you advise the woman when she's breastfeeding? Well, the issue with regard to safety in breastfeeding is determined by how much of the drug passes through into the mother's milk. So if it's less than 10%, that's generally safe. And also determined by the age of the infant. So if the infant is premature, then they are more sensitive, obviously. And as they get older, as they get nearer 6 months, their metabolism improves. So they are more tolerant of any drugs that transfer into the mother's milk. So you can use quite a lot of different things. You can still use non-steroidals. You can go back to using non-steroidals, I should say, because obviously you stop that in the 3rd trimester after 32 weeks. So you can go back to giving the mother ibuprofen or naproxen. Paracetamol she could use all along anyway. Triptans, the oral triptans have a lower transfer compared to the injectable sumatriptan. You can use domperidone, and in fact, people use domperidone to try and encourage lactation anyway. Nothing to do with the migraine aspect, but it's quite a good prokinetic antiemetic in migraine. I tend to use it a lot with naproxen, for example, as a combination therapy, and that works quite well in just in migraine in general. And then beta blockers and amitriptyline are still safe. You can go back to using candesartan. So candesartan we wouldn't use during pregnancy. You wouldn't use it if the infant is premature either, but otherwise you can go back to using that. And you can use topiramate, although about 25% of it gets through, and there is some risk of sedation. So as long as you're keeping an eye out for sedation, you could possibly use a lower dose of topiramate. Valproate I put in brackets because of its teratogenicity, and obviously if a woman's just given birth, she may not be on contraception. So that's the reason I put it in brackets, but otherwise it's theoretically okay to give during breastfeeding as long as the woman doesn't get pregnant again while she's taking it. So finally, the final phase is menopause. And again, it's nice to have some good news. The good news is that you can say to the woman that, 2/3 of people will get better at the menopause. But the bad news is that you have this little fluctuation. So you can see here, estrogen going up and down, up and down, up and down, and this peak here. So I often see this in my clinic about women coming into my clinic in their late 40s who have been very well controlled for years. And then all of a sudden they're getting a really bad exacerbation of their migraine. And that's this perimenopausal fluctuation of estrogen that's causing that. So you can treat them the same way you treat someone who doesn't have menopause with the same medications. But then the question is also, what do you do with hormone replacement therapy? What effect does that have? So there are some studies, a study in Norway suggesting it can have make migraine a bit worse, but there are other people who find that it helps because it reduces the fluctuations. If you are going to prescribe hormone replacement therapy for women with migraine, then you should use the transdermal patch rather than the oral formulation, because the transdermal patch gives a more continuous level of estrogen with less fluctuations. And as I mentioned, migraine is very sensitive to fluctuation. If the woman has an intact uterus, so if she's not had a hysterectomy for any other reason, she would also need to then be taking continuous progestin as well. If it's contraindicated and she can't take it, then you can try something like venlafaxine or escitalopram or clonidine, and those are other drugs that you can give during the menopause. And what about the stroke risk? Well, obviously there's concerns with hormone replacement therapy and risk of stroke, and there is possibly an increased risk of stroke with the oral formulation, but not with the transdermal patch. So that applies to just people in general rather than just women with migraine, in that their risk of stroke tends to not be increased in the transdermal formulation for some reason. There was a paper showing that. Canonical, the paper 2006, I think it was. So that's quite an important fact. So you'd also use a low dose of estrogen because of the concerns that I mentioned earlier. And interestingly, although the combined oral contraceptive pill is contraindicated in migraine with aura, using estrogen containing hormone replacement therapy is not contraindicated in migraine with aura. So just to summarize, migraine varies throughout the phases of a woman's life, and we need better data to try and determine the stroke risk in current migraine patients using the combined oral contraceptive pill. And in an ideal world, we'll treat them all on an individual basis with their individual risk factors. Thank you very much.
Your lecture is over, Dr. Shazia Afridi.
Thank you.
Dr. Shazia Afridi, can you hear me?
I can hear you, yes.
Okay, your lecture is over?
Yes, it's finished, yes.
Okay, thank you very much for covering a very important topic. There are no questions online. If from the hall somebody wants to ask a question, he or she is welcome.
Thank you, Dr. Shazia. It was a great discussion with respect to the women having headaches. In terms of the magnesium, especially in the first trimester, as per my discussion with the gynecologist, they usually don't recommend using magnesium in the first trimester. They were comfortable using magnesium because it's pretty safe from my perspective. But they recommended using it during the second or the third trimester of pregnancy or afterwards, but they were not comfortable using it during the first. So how was your experience with magnesium?
Well, actually, to be honest, I don't really use it very much because I don't find it that effective. But it was mainly looking at the data to see whether there was any risk of teratogenicity, and I didn't see any data to say that there was a risk associated with magnesium use in the first trimester. I think it may be to do with that study that I was mentioning, where more recently it's been noted that high doses of intravenous magnesium can be associated with fetal bone development issues. So I think it's probably related to that. That's the only concerning paper that I've seen, and that's come out quite recently. So up until then, people were using magnesium all the time. So I suspect if you are going to use it, you'd have to use it at a lower dose orally. So that relates to quite high doses. But actually, I've not had great experience in terms of outcomes with using magnesium as a preventative. And it's kind of one of those soft preventatives that people who don't like to take medications will try. But, there's some people don't like to take drugs. So, you can give them magnesium. And if they're not pregnant, you give them riboflavin as well. And then coenzyme Q, those kind of things, very sort of natural type medications that people like.
Dr. Shazia, there's a question by Dr. Ayazul Haq.
Yeah.
Most of the drug formularies suggest avoiding NSAIDs after 20 weeks of gestation. Your advice was that we can use NSAIDs up to second trimester of pregnancy safely. Will you like to comment upon this?
Yeah, so again, I reviewed the data on this. I did a paper in obstetric paper on looking at the risks. And so there are some studies, older studies, that suggest there's an increased risk of spontaneous abortion, but the more recent studies suggest that that's not really the case. There is another paper that suggests you have a slight increased risk of developing asthma if you take certain non-steroidals as well. So some people don't use it, in fact, during the first trimester, but do use it in the second. So there are people who are cautious about using it in the first trimester for that reason, and then they'll use it in the second. No one uses it after 32 weeks because of the reasons I mentioned. So, having reviewed the data, it doesn't seem like there is good evidence for the spontaneous abortion risk. But there was a paper mentioning some increased risk of asthma with some of the one of the non-steroidals. Indomethacin I wouldn't use, but naproxen and ibuprofen I do use.
That's all I have got questions. Thanks.
Dr. Fayaz Ahmed wants to ask.
As you know, if people have migraine without aura, but they have got a couple of risk factors, such as smoking or hypertension or diabetes, would you avoid oral contraceptive pill in them, combined oral contraceptive pill?
There's no evidence with hypertension I don't have the data on that. There is data to suggest if you're a smoker, you probably have an increased risk. But I think I would just advise them to stop smoking, because that is a modifiable risk factor. So I would say, look, if you want to go onto the combined pill, smoking increases your risk of stroke. So you really need to stop that or cut that down. And that is something that the woman can do to reduce her risk factor. That's, I'd say if you're a GP, you have to look at all these different risk factors anyway. But from a migraine perspective, I don't think that makes a difference, because if you've got migraine with aura, I don't think that increases your risk. So that would be the same as talking to any woman who is a smoker and on the pill. The advice, I guess, is what the GPs would normally say, you shouldn't really be taking it if you're smoking, and try and stop smoking first.
And what about diabetic and family history of stroke?
Family history of stroke, I guess, is a bit more relevant if it's young stroke. I don't think diabetes itself is a contraindication on its own, but I think if someone has diabetes, a smoker, family history of stroke, then clearly the more risk factors you have, then you're getting into increased risk of stroke. So I think in these patients, obviously the first thing you would do is try a non-estrogen containing pill anyway. So I wouldn't go straight to that in the first place. But the debate arises when patients can't tolerate that. So when they've tried progesterone-containing contraceptions and they can't tolerate it, and they have to be on something, and you've got to weigh up the risk and balance of them getting pregnant unnecessarily, and having a slightly increased risk of stroke. So it's very much, you have to tailor it on an individual basis, which is why I think, you need to give people an individual risk factor profile rather than having these laws that say everybody who has migraine with aura can't do this and can't do that. It's very much should be an individual risk factor decision.
Okay, ma'am. If there are no questions, we can move to the next talk.
Thank you very much.
Thank you, Dr. Shazia Afridi. We would like to hear in future from you on the forum of Pakistan Society of Neurology and Pakistan Headache Society. Thank you very much.
Thank you. Okay.
Thank
you.
Thank you, sir.
The next talk is by Dr. Fayyaz Ahmed on management of idiopathic intracranial hypertension. Let me introduce Dr. Fayyaz Ahmed. Dr. Fayyaz Ahmed is a consultant neurologist and professor in clinical neurology at the Hull University Teaching Hospital and Hull York Medical School. He is treasurer and director of the Board of Trustees of International Headache Society, and he is an educational officer for the British Association for the Study of Headache. He is an excellent teacher and very kind to spare his valuable time for Pakistan Society of Neurology and Pakistan Headache Society to enrich our academic activity. I would like to invite Dr. Fayyaz Ahmed for his valuable talk. Professor.
Thank you. Thank you for asking me to give a talk.
Dr. Fayyaz Ahmed, sir.
Yeah. Can you hear me? Can you hear me?
Yes, I can.
Yes, sir. We can hear you.
So thanks for inviting. I remember 2 years ago, the meeting was in Karachi and I was present myself in the venue. It's been not a good last year, not being able to go anywhere, but thanks for inviting. And it's lovely to be a part of an international meeting from the comfort of your own study room. So I'm going to talk about IIH, or idiopathic intracranial hypertension. I would like to acknowledge that one or two of these slides that I would be showing you is from acknowledging Alex Sinclair, who's done most of the work in idiopathic intracranial hypertension and is probably the world's most well-known figure in IIH. So let's, these are my disclosures. Sure. We're going to talk about what is IIH, who gets it, how we recognize it, how it is managed, and what's the current research going on in this field. So IIH is about raised intracranial pressure that causes papilledema, for which you are not able to identify any underlying structural pathology or any even biochemical pathology. Majority of these people are overweight, and majority of these patients are women of childbearing age. So I usually ask people to remember 3 F's: fat, female, and fertile. Although I don't think it's a very polite word to say fat, but it's the 3 F's that are the most common. Headache and visual symptoms are the commonest mode of presentation. If I show you the figures of being overweight or obesity in the world, Japan is leading with very little obesity, and USA is on the top. You can say United Kingdom here. This is data from Organization of Economic Clinical Development, and these are mostly European and developed countries. So there isn't very much data available from developing countries as such. And it's on the rise. This is the UK hospital data. You can see that the rise of the incidence is in the fertile age group, mostly between 20 to 40. You can see on the left that the general population, the IIH, is on the rise. That's because of being overweight or obese. This is at the bottom of the left, you see the incidence in men, and that's the incidence in women. And it is directly proportional to the weight obesity linked condition. How you would make the diagnosis? If somebody has got papilledema, then you do a neurological examination and it's all normal, apart from papilledema. Image, and the imaging is normal as well. You do a lumbar puncture and the CSF has got no abnormality apart from high pressure of 25. So if you've got all these A to E met, then that's definitely a diagnosis of idiopathic intracranial hypertension. If you've got A to D, and you do the lumbar puncture and the pressure isn't high, but they have got papilledema and others, then this is most likely or probable idiopathic intracranial hypertension. Now, some people don't have papilledema. They present with headache and visual symptoms, with the normal imaging, normal examination, normal CSF, but the pressure is high, but they don't have papilledema. And that's a condition that we will discuss later on. It's called IIH groups, which is without papilledema. So that can possibly, but we'll discuss it at the end. This is the IIH guidelines published in JNNP in 2018, mainly by Susan Mullen and Alex Sinclair. And it looks very complex, but each and every bit of it is very simple and would guide you what to do as and when the patient would present with symptoms or signs, and the lumbar puncture, management, and other things. So I will try to break them into pieces and show you exactly how we move on. It is very good to have this on your clinic, the wall chart, as a guide when you see your patient. So how would you investigate papilledema? So patient comes with headache and some visual symptoms, and you have a look at the fundi. I mean, particularly if it's the right phenotype, which is young female that is overweight and may or may not have oral contraceptive pill or smoking. The first thing is that if you find papilledema, make sure that the patient doesn't have a high blood pressure, as one of the reasons of papilledema could be malignant hypertension. If the blood pressure is fine and the papilledema is found, I usually ask my ophthalmologist to do a formal visual acuity and visual field testing. You cannot pick visual field abnormalities on confrontation. So therefore, I think the ophthalmologists are best placed to see whether there is a visual field defect. Because if there is a visual field problem, then this means that the vision could be at risk. The next thing I would do is would organize either an MR or a CT, whichever you like. Whichever you like, angiography has got to be in there. There is still debate about whether it's the MRV better or a CTV better. I would say that if you've got MR available, obviously radiation risk-wise, MRV is better, but CTV is as good as MRV. You make sure that there isn't anything in the MR, so there is no other cause, particularly venous sinus thrombosis. Then you do a lumbar puncture appropriately, preferably in the lying position with the knees and thighs flexed, patient relaxed. Because remember, we still don't know whether people who are overweight and don't have IIH may have a pressure higher in the higher range. Appropriately measure lumbar puncture. If the pressure is more than 25, obviously this is indicative of IIH. And you have excluded all the secondary causes, which we'll discuss in one more slide later on. And that's how you do the investigation of papilledema. Now, there is evidence that a lot of people are misdiagnosed with IIH. And that is mainly that the papilledema is not really properly diagnosed. You can see patients may have congenitally abnormal discs, which look like papilledema. They may have very severe hypermetropia or myopia, or there may be a myelinated nerve, optic nerve that shows like, appears to be like a papilledema or an optic nerve. If you wrongly make a diagnosis of papilledema, means you are making a wrong diagnosis. The patient is having unnecessary lumbar puncture. You may be treating them with treatment, bromide or topiramate. And in the past, we have seen people having a shunt. It doesn't happen that more nowadays, but going back 20, 22 years ago, we have seen people having shunt with wrong diagnosis of IAH. The latest and the very good predictor of or indicative of papilledema is the optic coherence tomography, or OCT. If you look at the bottom, that black line, if it is out of this green area, that usually shows that there may be a papilledema, or that's because this is out of the vein. So all the black line has to be placed within the green field. Therefore, I think before you proceed on to the lumbar puncture, if you're absolutely sure that the patient has got papilledema, then the role of the ophthalmology is just to check for visual field defect. You can go ahead with the lumbar puncture. If you are not sure whether the patient has got papilledema, then I think when you send to the ophthalmologist, ask that the reason is not just to do the visual field, but to confirm papilledema, and they would do an OCT and tell you whether this is papilledema or pseudopapilledema. These are four different sizes. So which one has got papilledema? You can see this is the true papilledema. It's fairly advanced papilledema because there are lots of hemorrhages around. Now here, that looks like papilledema. It's actually pseudopapilledema because you can still demarcate quite reasonably this margin. But yeah, I agree, this is not very prominent. A lot of people might think this appears like a papilledema. This is the myelinated nerve. And it appears as if it is swollen. And this is optic nerve drusen. That also will give you a feeling as if it is swollen. Now, I was trained in the era when very few investigations were liberally available, in the early 90s and late 80s. So I rely on clinical science more than investigations. I think these days with the pandemic, making all the telephone consultation, we scan everybody, we investigate everyone. We do not get a chance to do a good clinical examination. But if you do have a chance to examine, there is no substitute for a good clinical examination. Although I think most of the people with IAH is such a classical phenotypes that it would be very difficult to miss. But spontaneous venous pulsation, if you can find it, would be against papilledema. Or if it was previously present and you can't see it now, is an important thing. But if you're not good in finding venous pulsation, then I think your best bet would be the OCT and ophthalmology. So, what are the headache phenotypes in people with IAH? Well, there is no particular type of headache that would say this is the headache of IAH. I mean, the studies have shown that the only thing patients with IAH have more significant is headaches or coughing, and not with any other Valsalva maneuver. All other Valsalva maneuvers, the control population were as common as with IAH. The phenotype is usually migraine, and the migraine would be, as usual, you see people with chronic migraine that about 2/3 would have medication overuse. About 40% patients would have medication overuse. So you cannot say that these patients give a history of IAH. It's the phenotype of the appearance and the risk factors that make you think, not the characteristic of headache. It's a wrong thinking to say that that patient is having headaches, which is typical of IAH. Among the non-headache symptoms, visual obscuration, not blurring of vision, visual obscuration is present in about 2/3. And pulsatile tinnitus is also far more common in people with IAH type of blurred vision, neck pain, back pain, dizziness, and some other features have been described, but they are all relatively uncommon and probably not more common than the general population as such. So what are the imaging findings in IIH? As I said, you can do MRI or CT, but must include the venography. There isn't anything but, diagnostic of IIH. The finding that you see on the imaging is mainly to exclude venous sinus thrombosis. That's the main thing. Obviously, you exclude other space-occupying lesions like hematomas and tumors. But if there is no pathology, the main findings of IIH is related to raised intracranial pressure. And on your left here, you can see tortuous optic nerves and more CSF around the optic nerve, which would mean that there will be papilledema, and that you can see that there is a raised optic disc margin here. So that's papilledema. See, empty sella is another good sign. Venous sinus narrowing. Now that's a bit of a problem because sometimes this is the cause and sometimes this is the result of the IIH. But in patients with IIH, nearly 100% people would have either unilateral or bilateral venous stenting. So be aware of the fact that in the normal population, you can see about a third of the normal population has got unilateral venous sinus stenosis, and about 5% have bilateral. So just keep it in mind that this could be just a normal finding as it has to be taken in context with the clinical treatment. The other thing is flattening of the globe, posterior globe, and that's another very good feature of raised intracranial pressure. What's your differential diagnosis? Well, the main thing is that you have to exclude other causes of raised intracranial pressure. Top of them is obviously very obvious causes of tumors and subdural, extradural blood clots or hematomas. Cerebral venous sinus thrombosis is the main because obviously young females and particularly overweight and smokers or on the pill, that's what you think of. So this is the main thing that you need to exclude. There are others. I haven't come across many patients with anemia or sleep apnea, but obviously these are the ones described as secondary causes. You can have papilledema as a result of raised CSF proteins such as Freund syndrome and Guillain-Barré syndrome. So make sure that patients with papilledema you do the CSF, and the CSF is of normal composition. There are some drugs involved with it and some endocrinopathy. So make sure that your list is ticked, that they are excluded or basically there's no obvious features of any of these. So 3 management strategies, mainly to protect vision. Secondly, to improve headache. And third is managing the underlying problem. The underlying problem is weight management. Weight management is the main problem, and it's curative. If you ask patients if they lose weight, IIH would go away. So let's start with protecting vision. If patients have got visual obscurations and you find that their vision, they have got visual field defect and their vision has got worse over a period of time, you can do a lumbar puncture. And you also ask for a temporary lumbar drain. If the vision is getting worse, that's what we call a fulminant IIH. And you either could do optic nerve sheath fenestration as an emergency procedure, or you could suggest CSF diversion. And BP shunt is the best option. But some people can do lumboperitoneal shunt. The ventricular peritoneal shunt is. So that is for vision. So visual symptoms, do a lumbar puncture, confirm the high pressure. If the vision is deteriorating, refer the patient for either of these procedures. If the patient presents with headaches, then manage the phenotype. If the patient presents with migraine headache, manage it as migraine. You only do lumbar puncture to diagnose IAH. You don't do lumbar puncture to improve headaches. Remember, IAH, if you do a lumbar puncture, 3/4 of the patient would improve in terms of headache. But then about a quarter would also improve even if they don't have IAH. Even patients with migraine, tension headache or others would still improve. And remember, the old belief that people, if they have got IAH, they don't get low CSF pressure headache is not true. About a quarter of patients with IAH, when you do the lumbar puncture, would then go on and develop the low CSF headache. I remember people saying that if people develop a low CSF pressure headache, that excludes IAH, but that's not true. Then we got the weight management. The other management strategies that have been are still being tried, and some evidence anecdotally has been published in neurovascular stenting. Currently, as such, there have been some anecdotal data on numbers, observational studies, but currently there is no role in neurovascular stenting as such. What about serial lumbar puncture? And I think it was quite a common practice in the late 90s that people with IIH presenting to A&E with a headache, they would do the lumbar puncture. And I still remember a lot of people were coming in the daycare for a lumbar puncture. Even when I was training in Charing Cross Hospital in London, most of our day cases were lumbar puncture for IIH. There is no role for serial lumbar puncture. The role of lumbar puncture is initially to make a diagnosis. You could do a lumbar puncture if you feel the vision is threatened before the proper procedure is done. There is no role of improving headache because you take the CSF, it's immediately replaced. So avoid doing, or not avoid, don't do lumbar puncture for headache alone. And then obviously weight management, which is quite therapeutic for both headaches, vision, and eye intracranial pressure. There is currently a study going on is whether community assisted or physician assisted or medics or paramedic assisted weight loss versus bariatric surgery. Any of them, which one is better, is to be seen. What about the medical treatment? So you find a lumbar puncture, the pressure is high. Well, acetazolamide is the commonest treatment that is being used. The evidence is not too great to either recommend or not too weak to reject. But that is the only one that is we have got available, and the Cochrane database has shown that you can use it. It's poorly tolerated, so if there are side effects, don't continue. And most common symptoms are paresthesia, tingling in the hands and feet. Topiramate does reduce intracranial pressure and reduces weight loss as well, so that would assist in that one. Again, poorly tolerated with cognitive side effects. So I think because of the teratogenicity or cognitive side effects, I think people still use acetazolamide as a first line and may not introduce topiramate. The good thing about topiramate is a good anti-migraine prophylaxis, and the headache phenotype is migraine, so you can use topiramate. I tend to use diuretic like bendrofluozide 2.5 or 5 milligram. There isn't any evidence. I find it works for my patients. That's just a personal experience. You manage headache phenotype. So if it is migraine headache, you manage it as a migraine with acute treatment with NSAID or triptan, and you manage prevention similar to what you do in normal migraine. These are the top 4 drugs that we use for migraine: laxative beta blocker, tricyclic, candesart, and topiramate. So whatever is indicated. If it is medication overuse problem, then obviously detoxify them, put them on preventive, ask them to come off the painkiller. If there is papilledema, you have to assess vision. If the vision is getting worse, LP and CSF diversion. If there is papilledema, if there is no visual symptoms, if there is papilledema, but the vision is stable, you don't need to do any lumbar puncture. Just keep them on medical. So just going to say a couple of words about IIH without papilledema. So IIH without papilledema or IIH both female with obesity, headache, but no visual symptoms. Papilledema is not there. That's what without papilledema. Imaging findings are very same. Some patients present with uni or bilateral sixth nerve palsy. People tend to overdiagnose it. Once people have known that you can have IIH without papilledema, I think people are making more diagnoses, and that's not true. But look at the main definition. So if you got BCDE, either unilateral or bilateral sixth nerve palsy, and you've got some good evidence of imaging findings of raised intracranial pressure, you can call it IIH. Okay, so it's a disorder of the 3F. You must include venography as your investigation of choice. The role of lumbar puncture is to make a diagnosis, or when people are awaiting a CSF diversion and have visual symptoms. No role for serial lumbar puncture or LP for headaches. Topiramate acetazolamide remains the medical treatment, and weight management is the key. Thank you very much.
Thank you, Dr. Fayyaz Ahmed. There are no questions in the chat box. If there are any questions from the hall, you are welcome. You can ask questions in the chat box.
You have one question from the audience.
Assalamu alaikum, sir. I'm Dr. Fawaz Ali from Swat. I had a question that if a patient had got fulminant papilledema in the case of that IIH, and for any reason the surgery is delayed. So in this condition, how much amount is recommended to do the therapeutic tape, and how often we will do it? Whether we do it on alternate base or just one will be sufficient? The therapeutic tape, its amount and its frequency. Thank you, sir.
But you have to just bring the pressure down from whatever the pressure is. You bring it down to about 15. Usually you take about 20 to 25 mil away and bring the pressure down to 15. You can do one lumbar puncture if the vision is threatened. You just can't do lumbar puncture just to improve headaches. There is another question from Ayaz about androgen axis in IIH. Well, it's very well known that androgen axis is related to IIH. There are steroids also axis related to IIH.
Hello, Dr. Fayyaz, can you hear me?
Yeah, I can hear you. I'm just waiting for a question.
Okay, there is another question by Harun Khan in the chat box. In case of threatening visual field, which CSF diversion method is best?
Ventriculoperitoneal shunt is preferred compared to lumboperitoneal shunt. I think ventriculoperitoneal shunt is being favored by many people.
Any other question from the hall or online?
One question.
If there are...
What is the role of stenting of transverse sinus or fenestration if VP shunt is not preferred by the patient, or if it's not suitable? Or what is is there any superiority of fenestration of optic nerve sheath versus VP shunt?
Yeah. So stenting has got no role. There's only one center in the UK who does it in Cambridge, but there is no evidence that it works as such. So at the moment, there isn't any evidence. As regards to optic nerve fenestration, well, this is a procedure that is done if the vision is threatened and the CSF diversion, other procedures are not available. But I've only referred 1 or 2 cases for optic fenestration because the patient could not be referred to have an emergency procedure. But usually I would prefer a patient to have a ventricular peritoneal shunt.
Assalamu alaikum. I have one question. Is there any role of steroid in case of visual impairment in idiopathic intracranial hypertension? Can we use them as a bridging therapy while waiting for the surgery?
Now, there is no role of steroid. As a matter of fact, steroid is one of the causes of IIH patients with steroids. So giving emergency steroid has got no role. There is another question about the diuretics. I find it helpful. There is no evidence. I give it to my patients, particularly if they can't tolerate acetazolamide and topiramate. I use a small dose of bendofluoride. It's not based on the evidence.
Assalamu alaikum, sir. I have a question, sir. If the patient is obese and the cause of that IIH is obesity, and if that patient loses weight and his or her BMI become normalized, so are there studies that the IIH will go away or they need treatment for a prolonged period, medical treatment?
Well, the patients that I have seen who have had bariatric surgery, the IIH had gone away. Some of the patients, I've got about half a dozen patients after bariatric surgery. We had to bring them off the medication within a couple of years, and they're cured. So, yeah, going back to normal weight would more or less cure the patient. There is a question from Haroon Khan. What will be the dreadful complication of IIH without papilledema? Well, IIH without papilledema, there is no danger to the vision because they don't have visual symptoms. There is no papilledema, so there is no threat to the visual loss. What is the dreadful complication? Well, there isn't. I mean, they usually present with headaches, and all you do is make a diagnosis of IIH without papilledema through doing a lumbar puncture, or the imaging evidence has shown that they have got raised intracranial pressure, and you manage them medically, not with lumbar puncture, with the phenotype of migraine acute or preventive treatment. The good thing is that there is no danger to vision because there is no papilledema.
Any other question?
Yes, I have a question, Dr. Adnan. I'm Dr. Adnan. Sir, I just wanted to know, instead of acetazolamide, which is sometimes not available in the market, and topiramate, I've found that it is not very effective. Can we use this Lasix and etc.? Because I read it somewhere that you can use that, and sometimes we used to use it. So I just want to know, can we use that medicine? Because most of the people don't go for lumbar puncture because then they keep on cursing you for the whole of their life. That you have given me backache on. So one tries to avoid repeated lumbar punctures.
Well, I use diuretic. I commonly use bendrofluomethazide or bendrofluozide. You can use furosemide. There is no evidence that diuretics work, but they do work anecdotally, and I think some of the other colleagues have got some experience with it. The take-home message is that doing a lumbar puncture has got a placebo effect, basically. It would improve the headache for the first 24 to 48 hours, and it would all come back again. So I think take this myth away that people with IIH need a lumbar puncture to relieve their headaches.
Sir, I have another question. Although I wanted to ask it from Dr. Shazia. What about the devices that are like Kefali, that electric devices that people wear? And are they effective, and are they safe in pregnancy, and can we use it?
So TMS, transcranial magnetic stimulation device, that has been used. There was case reports of, I think, 4 or 5 women who've used that. That is safe. So they are safe. But for example, the TMS is no longer manufactured, unfortunately. Kefali is probably also safe too. There are less studies on these things, but I think theoretically they should be fine. As to how effective they are is a different question, though. But some of them are no longer available, unfortunately, because of manufacturing and the company going bankrupt, I think, particularly the TMS one.
Thank you, Dr. Shazia. Any other question? If there are no questions, I will request Chair of the session, Professor Adnan Khan, President Pakistan Headache Society, for his concluding remarks, please. Professor Adnan Khan, sir.
Thank you very much. I'm very thankful and grateful to all the speakers and all the audiences for listening to very, very nice lectures and informative lectures. We did not cover these topics in our previous headache conferences. So thank you very much, and thank you for giving us your time. May Allah bless you.
Thank you, sir. And over to the organizers.
Okay, thank you, everybody. Thank you, our respected speakers. And now we are not taking tea break. So as this conference whole is about research and education purpose, and our main theme is also strengthening academics in neurology. So we will take this opportunity. And for this, we have given space for research papers. So now I would like to call upon Dr. Sundus Mehtab Shafi to present the paper, research paper.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I am Dr. Sundus Mehtab Shafi, neurology trainee at Dow University of Health Sciences. Today, on the behalf of Department of Neurology, Civil Hospital, Karachi, I'm presenting a research on factors affecting the prognosis of status epilepticus among patients presenting to a tertiary care hospital. So others declared that there is no conflict of interest and there is no external source of funding for this research. Epilepsy is a significant medical issue that influences more than 50 million people around the world, and 80% of whom 80% of the affected people are living in developing countries or in third world countries. And status epilepticus is a neurological emergency which is associated with high morbidity and mortality, if not managed promptly or not managed with specific therapy. However, local data is insufficient regarding the socio-demographic variables or ecological factors or clinical factors underpinning the disease prognosis and outcomes. So the objective of our study was to investigate the outcomes which were associated with status epilepticus in a tertiary care setup and identify the key prognostic factors affecting mortality and morbidity among the patients. Study design was a retrospective observational study, which was conducted at the Department of Neurology, Dr. Ruth Kempfau Civil Hospital, Karachi. All the patients who were admitted in neurology ICU with status epilepticus from the period of July 2015 till June 2020 were part of that study. And patient management was done according to the standardized treatment protocol. It was followed like initial administration of IV benzodiazepines, then followed by anticonvulsants and IV anesthetic agents as needed. Airway was secured and continuous monitoring was instituted for all the patients. Multiple variables like age, gender, residence, and clinical comorbid conditions were noted from the data. Clinical course in hospital management and the response to therapy were also noted. Follow-up assessment of sequelae and data regarding patients' progress over the following 6 months were acquired from the record. And etiologies of status epilepticus were divided temporally as acute or chronic and considered separately as primary, that is with having no identifiable causative factor, and the secondary one, which is due to a distinct disease entity. So we included all the patients who were admitted in neurology ICU with status epilepticus from July 2015 till June 2020, and patients above age of 12 years were part of this study. We excluded the patients with non-convulsive status epilepticus. The rationale was that we do not have a 24/7 or the round-the-clock EEG available in our setup, so we cannot include the patients with non-convulsive status epilepticus. And patients with incomplete record or those patients who were initially managed in another department or in another ICU were also excluded from our study. And patients who were taken against medical advice before completion of treatment were also excluded. So the statistical analysis was performed using SPSS version 21. Descriptive statistics and frequencies were calculated. Chi-square test with 95% confidence interval was used to compare the categorical variables. An analysis of variables with small cell scores was computed using Fisher's exact test or likelihood ratio as appropriate. Non-parametric tests were used to compare the differences in continuous variables across the groups, and a 5% significance level was used throughout the study. In 2015, International League Against Epilepsy defined status epilepticus as seizures lasting more than 5 minutes for generalized tonic-clonic seizures and more than 10 minutes for focal convulsive seizures, or recurring seizures lasting more than 5 minutes without returning to a normal level of consciousness in between the episodes. While refractory status epilepticus is a continuous seizure activity, which is not going to control by first-line and second-line anti-epileptic drugs, and whenever the status epilepticus is not controlled by third-line agents, or if status continues for 24 hours or longer after administration of anesthesia, this is like super refractory status epilepticus. Here in our study, morbidity refers to the development of cognitive impairment, motor deficits, and active epilepsy alone or in combination as a complication of SE. And scar epilepsy refers to a delayed presentation of epilepsy as a sequelae of previous cerebral insults like tumor, trauma, any cerebrovascular accident, or surgery. So our results showed that 176 cases of status epilepticus were recorded during the study period, while mortality was reported in 22 cases, that makes around 12.5% to 13%, and morbidity reported in 44 cases, that makes around 29% of the cases. Among them, I'm talking about morbidity, that the cases were 44. Among them, 17 patients developed motor deficits, 12 patients developed active epilepsy, while 7 patients developed cognitive impairment, 8 patients developed cognitive impairment, and 7 patients developed the mixed type of morbidity. So the socio-demographic results or the location demographic results showed that most of the patients, around 64% of the cases, were resided in the urban area. And when we did gender comparison, we found that most of the cases were males. This table summarizes the socio-demographic characteristics of our study. The first one is about the gender comparison, which I have been told that the males were more in our study data. and that makes a percentage of around 55.7%. A majority of the patients had not received any formal education, and a positive family history was reported in only 5% of the cases. A previous history of status epilepticus was found in 13.8% of the cases. As far as association with mortality and morbidity is considered, male gender was strongly associated with mortality with a p-value of around 0.002, but not with morbidity. A previous history of status epilepticus was significantly associated with mortality, while rest of the variables were not significantly associated with mortality and not even with morbidity. The median age of our study population was 24 years, and no significant association was found between gender, between age and mortality. Okay, results of etiology of epilepsy showed that the most common cause of epilepsy was found to be CNS infection, and it was followed by idiopathic epilepsy and scar epilepsy, which is a sequelae of other etiologies. So in this table, you can see that there are etiological characteristics of status epilepticus. Most cases of SE occurred after a previous history of epilepsy. That makes around 78% of the cases. And de novo cases, which is usually secondary cases, were found in 21% of the cases, and they were associated with greater morbidity with a p-value of 0.00, but not with mortality. Secondary and acute cases of SE were associated with greater morbidity as compared to the primary ones, and no such association was found with respect to mortality. While CNS infections exclusively were more strongly associated with mortality with a p-value of 0.00. Results regarding the provocative factors showed that 38.6% cases of SE were provoked by non-compliance to anti-seizure drugs, followed by infective etiologies, while seizures with unknown provocative factors make up around 11% of the cases. Significant differences were noted in the rates of mortality and morbidity according to the type of provocative factors. Highest mortality rate and even the morbidity rate was seen in patients with infective etiology. As far as clinical characteristics of seizures are considered, these are 3 graphs which showed that the most common type of seizure reported during our study was generalized tonic-clonic seizures, which makes around 88%, and 58% of the patients presenting with SE reported poor seizure control in the preceding 6 months. Most cases of SE were found to be responsive to medical management. However, refractory SE was observed in 11.8% of the cases, and super refractory status epilepticus was found to be around 2.4% of the cases. So the type of seizure in SE was not significantly associated with mortality or morbidity, but refractory and super refractory SE was strongly associated with higher mortality with a p-value of 0.00. This table summarizes a temporal profile of seizures. The median recorded seizure duration was 60 minutes in our study. The median hospital stay was 7 days, and the median time to hospital arrival was 45 minutes. Longer seizure duration was associated with higher mortality. Length of hospital stay was significantly associated with higher morbidity, while delayed arrival to hospital was significantly associated with higher mortality. Moving towards discussion regarding our study and literature search. So in our study, mortality of about 12.5% was reported, while in a study which was conducted in California in 2002, they reported the overall mortality of around 10.7%. And in another study that was conducted again in California, but in 2015, they reported the overall mortality for status epilepticus in adults of about 20%. In our study population, the most common cause of epilepsy was CNS infection, which makes around 30% of the cases, and most common provocative factor was non-compliance to anti-seizure drugs. A same pattern of study that was conducted in Italy concluded that the most common cause of SE in their population was cerebrovascular accidents. An American study conducted on the clinical features and outcomes of 98 patients with status epilepticus concluded that the most common cause was discontinuation of anti-seizure medication, and it was found to be around in 53% of the cases. In a study conducted in Norway, the poorer outcomes were reported in patients with de novo SE compared with the patients who had previously known epilepsy. In another meta-analysis conducted in Beijing, it was analyzed that acute symptomatic etiology was the leading cause among patients with status epilepticus. And in our study, which is compatible with the literature, de novo SE was related with greater morbidity, and the p-value was around 0.00. This is probably explained by the nature of the underlying conditions, as de novo seizures more often represent acute medical and neurological diseases. In 2017, a Turkish study concluded that the potentially fatal etiology was related with poor short-term outcomes without reaching the statistical significance. However, we found that CNS infections were more strongly associated with mortality. Relevant researches which were conducted in Thailand showed that outcome becomes poorer when status epilepticus lasts longer. It is compatible with our results as it showed that prolonged seizure activity and longer interval between seizure onset and hospital arrival was associated with higher mortality. Large epidemiological study, which was conducted in America in 2014 regarding convulsive status epilepticus, found a slightly higher mortality in males, while European study, which was conducted in 2016, failed to find any relationship between gender and outcome. However, we found significant mortality among males, and the p-value was 0.002. One study was conducted in Virginia, reported that the most frequent seizure type was focal onset seizures in their study, and it was followed by generalized tonic-clonic seizures. And our data showed that the most common type of seizures in SE was generalized tonic-clonic seizures, and the reported cases were 88%. So there were some limitations of our study, like it was a retrospective study and data from a single tertiary care hospital was included. Regarding the strengths of the study duration is longer, like it is around 5 years, an adequate sample size, as we can see in the literature search as well, that mostly the sample size is below 100. So our sample size is adequate enough, and socio-demographic variables are part of the study, and most of the data and results are compatible with international data. So we can conclude that prognosis of the patients presenting with status epilepticus is influenced by socio-demographic and clinical variables. Male gender, poor control of seizures, CNS infections, prolonged seizure duration, delayed hospital arrival, and refractory or super-refractory status epilepticus were the key determinants of mortality in our setting. While previous history of status epilepticus and cases with acute and secondary etiologies were associated with higher morbidity. Here are a few suggestions for the future. That firstly, public awareness programs should be conducted to emphasize on modifiable factors, including drug compliance and seizure control, as these factors can alter the outcome of patients. Secondly, it's high time to build epilepsy centers in rural and underdeveloped areas in order to minimize mortality and morbidity. And last but not the least, that local data regarding prognostic markers is required to provide high sensitivity and specificity in predicting the outcomes of status epilepticus. This is all from my side. Thank you so much for giving me this opportunity and for your attention. If you have any questions, I'll be more than happy to answer those. Yeah. Yeah, actually, sir, that's a very relevant question. We included the patients whose age were above 12 years because according to the admission protocol in our setup, Civil Hospital Karachi, we have divided on the basis of age into two groups. The patients were divided into two groups. Like patients who are below 12 years are dealt with pediatricians primarily, and patients who are above 12 years are, we the adult neurologists are dealing those patients. So actually in our setup, whenever the patient with status epilepticus comes to the emergency department with obviously continuous seizure activity, they are actually primarily and initially admitted and dealt with by the pediatricians. And we have to follow those patients. So because the inclusion criteria, because we have excluded all those patients which were not admitted in our ICU and were not were not initially managed by us. So we excluded the patients below age of 12. Okay, so yeah. Gigi. Actually, sir, the basic protocol or the basic standard protocol for the management of status epilepticus is very well known. And we usually try to follow the same protocol, same international protocol as it's given. So, but obviously, due to the non-availability of some drugs or obviously the setup circumstances, we are bound somewhere. But usually in our setup, in our department, we start with the same way, the airway breathing circulation, we maintain the saturations and all that, blood sampling. And after that, initially we give IV benzodiazepines, including lorazepam or diazepam, whichever is effective. We can repeat the dose as well if seizure is not controlled. And afterwards, we give a trial of anticonvulsants as it is in the protocol, including the phenytoin or phosphenotoin or levetiracetam as well. But still, if the patient is in refractory status epilepticus or super refractory, we have to give IV anesthetics and we have to intubate the patient. So we do the same. And so I have mentioned that IV anesthetics was not given in all patients. It was given in those who were in need of who are in need of this. Any other question? Thank you, sir. Thank you.
Okay, thank you. So our next paper, that is of Dr. Sagar Thareja. Please come.
Good evening. Assalamu alaikum. I am Dr. Sagar Kumar, working as a resident neurology, Dow University of Civil Hospital, Karachi. Today, I am going to present a case report on orofacial and palatal myoclonus as the presenting symptoms in primary progressive multiple sclerosis. Case history: a 40-year-old male patient, resident of Afghanistan, labor by profession, and he was present in neurology ward with clinical complaint of abnormal movements of face and hands since 1 year, slurring of speech since 1 year. This is given by patient attendant that he was in usual state of health 1 year back. Then he started developing gradual in-onset twitching and jerking of facial muscles, including lips, tongue, and palate, followed by jerking of right hand. These were persistent during sleep and waking hours. These abnormal movements were associated with difficulty in speaking and swallowing. And symptoms were persistent and progressive in intensity over the period of 1 year. There was no associated history of facial pain, weakness, paresthesia, headache, dizziness, blurring of vision, seizures, or incoordination. Systemic review was normal. Past history and no previous history of hospital admission, surgery, or trauma. Personal history, no history of addiction. And no any family drug history or transfusion histories. On the general physical examination, a middle-aged male patient sitting comfortably on bed of normal height and weight, oriented well to time, place, and person. His vitals and sub-vitals within normal limits. On the neurological examination, his higher mental function was intact, speech is dysorthric, motor and sensory examination normal. As far as the specific examination of abnormal movements, The phenomenology of movement disorder, there were abnormal jerk-like movements of the orolingual facial muscles involving lips and tongue that can be best described as persistent, involuntary, and non-suppressible jerking of muscles in these regions. And these suggestive of myoclonic jerks. Look at this. This is the facial twitching and jerking muscles. And there's myoclonic jerks in the right end. This is the second figure in which we can appreciate the jerking movements of tongue and palate. His systemic examination were unremarkable. Now the investigation. First of all, we have done the MRI brain, which indicate MRI brain T2-weighted images, which shows there is a lobulated hyperintensive periventricular signals. And these are the heterogeneous signals on the coronal flare. And there is no any contrast in post-contrast enhancement of these lesions. While the MRI cervico-dorsal spine with contrast were unremarkable. The CSF DR showing there is increased protein, that is 60, and there is a oligochronal bands present in CSF. No matching bands detected in the serum. And all the baseline investigations were within normal limits. And workup of Wilson's disease is also done because these movements are mostly commonly associated with the Wilson's disease. However, the further workup, including viral markers, autoimmune profile, and stool DR, were within normal limits. And the VEP and EEG was also done, they are also in normal limits. So after all these investigations, now we will move to our final diagnosis. That this patient has a progressive history of abnormal orofacial and hand muscle jerks with more than 2 T2 MRI lesions and positive oligochronal bands, and suggestive of primary progressive multiple sclerosis with unusual presentation as orofacial and palatal myoclonus. And this patient was managed in our ward symptomatically and by immunosuppression. These are some of the literature view in the movement disorder and multiple sclerosis. This study is published in Movement Disorder, and a study conducted by the Trock and Bhatia, in which they report 14 new cases, of whom 9 had dystonia, 3 had Parkinsonism, and 2 had myoclonus. And they concluded that the proximal dystonia myoclonus bellismus can be caused by demyelinating lesion. And this is the first case reported of the oculopalatal myoclonus in multiple sclerosis. This was a study conducted in the French, they reported in the 1990. There is some another literature in which the movement disorder, the coincidental association with multiple sclerosis. It also concluded that the MD in patients with multiple sclerosis are often secondary to demyelinating disease. And this is this is literature of the movement disorder in multiple sclerosis and other demyelinating disease. They also concluded there the restless leg syndrome, dystonia, myoclonus, and these are the rare associations of movement disorder associated with the MS, NMO, encephalomyelitis, and pontine myelinolysis. So in the last conclusion, our case supported by review of literature favors considering the differential diagnosis of multiple sclerosis in establishing the etiology of movement disorder like orofacial and palatal myoclonus. However, this should be well supported by the appropriate investigations and imaging. Thank you.
You mentioned that there was no contrast enhancement on MRI, isn't it?
Yes, sir.
So if you're saying this patient has multiple sclerosis, he should have some contrast enhancing lesions, right?
So maybe this part is old lesions that cannot be enhanced on.
So according to the modified McDonald's criteria of time and space, you do have lesions, but to fulfill the criteria at some point in time, this patient should have enhancing lesion. With non-enhancing lesions, you won't be able to fulfill your VP was normal. Legal clonal bands in the CSF is an additional criteria, but it's not the major criteria. So, I mean, I'm not sure who was the consultant who saw the case with you, because we had a similar case who ended up having paraneoplastic syndrome. So the only concern I have is that it was paraneoplastic panel done on this patient.
Yes, sir, we have done all the workup, autoimmune profile, also for the Wilson's and also for the viral markers and HIV. These all came to be negative.
Right. It's a great case. It's a great case.
Thank you so much.
Thank you.
Can you tell me what medicine did help him out?
Can you please repeat the question?
Can you tell me what medicine did help him out? I'm Professor Dr. Adnan Khan from Peshawar.
Sir, this patient was managed by the immunosuppressive drugs and symptomatics. In symptomatic, we give him the clonazepam, sodium valproate, corticosteroids, and while on the immunosuppression, we started the DMT.
No steroids were used.
The steroids were used, sir.
Steroids were used, okay. Thank you. Thank you very much for a nice lecture.
Thank you, Dr. Sagar. So, thank you, Dr. Sagar. So, we will now move toward the next paper. I would like to invite Dr. Sadaf Bano for her paper.
Assalamu alaikum, everyone. I'm Dr. Siddarbano Qureshi, neurology resident from Dow Hospital, Dow University of Health Sciences, Karachi. Today, I'm here to present an interesting case with all of you of Klippel field syndrome with mirror hand movements. This is not my Dr. Siddarbano. So before going through our case presentation, let's have some few words about Klippel field syndrome. So Klippel field syndrome is a rare disorder of unknown etiology characterized by congenital fusion of at least 2 cervical vertebrae. It is a heterogeneous condition presenting with a spectrum of skeletal and extraskeletal manifestations. The classical triad, which is associated with the Klippel field syndrome, contains a short wave neck, low posterior hairline, a restricted range of cervical motion. There are various pathogenesis was suggested regarding this Klippel field syndrome, various dominant and recessive genetic mutation, including growth differentiation factors like GDF6, GDF3, MEOX1, RIPLY2, which are all responsible for transcription regulation and signaling pathways involved in somite development during embryogenesis. The incidence of this condition is in 1 in 40,000 to 50,000 live births, and with the equal distribution in males and females. There are certain associations with this condition in which cervical scoliosis, sprangial deformity, hearing impairment, congenital heart disease, lung defects, and genitourinary malformation. The rare association with this Klippel field syndrome we found in our patient was synkinesia, or mirror movements. That is voluntary unilateral movements of a limb causing involuntary movements of the homologous muscles of opposite limb, which were reported only in 18% of the patients. So mirror movements associated with the Klippel field syndrome are usually limited to the upper extremities, occur distally, and tend to remain stable or regress with age. So let's start with the case presentation now. So we had a right-handed 14-year-old boy, a student by occupation with no known comorbids, presented in outpatient department of Dr. Ruth K.M. Pao, Civil Hospital, Karachi, with complaints of involuntary movements of one upper limb, identical to the voluntary movements of opposite upper limb since 2 years of age. These movements were first noticed by his parents at the age of 2 years and were described as involuntary identical movements occurring in one upper limb induced by simultaneous involuntary movements in the opposite upper limb involving both hands, wrists, and forearms. There is no involvement of the elbows, shoulders, face, lower limbs, or other parts of the body. These movements were more severe and prominent in the left upper limb as compared to the right, resulting in fatigue and wear out over time. The patient described his movements as having gradually and mildly improved over the course of his duration. For ruling out and ruling in certain associations, we asked certain questions from our patient. None of these symptoms were present in our patient. For in developmental history, he was born at full term with no reported complication during delivery. His developmental milestones were achieved on time. There was no family history of similar illness or any other medical conditions. On examination, his vitals were within normal limits. Now, on moments examination, so moments we noticed were present on pronation and supination of the forearm, the flexion and extension of wrist and individual fingers. These moments were more prominent in the left upper limb as compared to the right. Patient was able to partially control these movements by clenching fists or by grasping things in hands. Let's evidence the movements. So we asked our patient to write down from his dominant hand, and you can easily appreciate it that there are the same fingers and thumbs, more prominent movements in this finger and thumbs, exactly in the same way, the way he's using his right hand. When we asked him to write down from his non-dominant hand, the same posturing and the movement in the same way was mimicked, like his voluntary movements in the right hand. But these movements were in less intensity when we note, which were we witnessed in